Thank you, Dr. Evidente, for inviting me today. Welcome, everyone. I know some of you, in fact, this is a reunion of sorts. I know many of you, and I look forward to meeting the rest of you. Somebody's going to ask me today, what is the difference between Alzheimer's and dementia? That's one of the questions I'm sure I'm going to get. And then the other question I'm sure I'm going to get is, am I getting Alzheimer's or memory loss? So we're going to talk about both of those things today. So people ask me about Alzheimer's. Alzheimer's is the disease. Dementia is the end stage terminal phase of the disease. I'll spend a little time trying to differentiate those for you to understand that one is the category and the other is the type. But these are very, very common. I know I come to Fountain Hills and I realize that one of the bigger retirement areas, although it's not a retirement, official retirement, bigger retirement communities in the region. And the reason I say this to you is that Alzheimer's is growing. Even though the incidence per 100,000 is going down, we're still talking about almost 7 million people. We're talking about 14 million in America by the middle of this century, and it is one of the biggest causes of cognitive decline. Again, so I want to spend a moment to talk about what's called a categorical definition versus etiological. People say to me, I don't have dementia, I don't have Alzheimer's, I have dementia. It's kind of like saying Parkinson's and movement disorder, or cancer and breast cancer. One is the category, one is the type. Okay? It's important that you all understand this. Dementia is the category of disease. Dementia means that you have memory loss or cognitive decline bad enough to affect your daily life. It is a category of disease. You could have dementia from Alzheimer's, Parkinson's, Lewy body, strokes, water on the brain, et cetera, et cetera. Cancer. So when you have cognitive decline with loss of independence, you have dementia. If you have cognitive decline, but you're still independent, you have mild cognitive impairment. Another way of saying not normal for age and not severe enough to be dementia. These are categories of disease, like movement disorder and Parkinson's. Okay? Everybody got this? Because we're going to keep going. So I always say mild cognitive impairment or dementia due to Alzheimer's, Parkinson's, Lewy body. And there's a long list of things that cause dementia, including Parkinson's, by the way. Dementia, second after Alzheimer's, is Lewy body dementia. I know a couple of people in this audience who are my patients who have Lewy body. It is the second most common type of dementia after Alzheimer's, not vascular, not vascular. Vascular would be third. If you actually take those three, you're talking about 88% of all dementias. So these are very, very common. And then, of course, water on the brain. Syphilis used to cause dementia. Nobody has syphilis anymore, thank goodness. But a lot of things cause dementia. Lou Gehrig's disease can cause dementia. Parkinson's can cause dementia, etc. So there are many, many causes of dementia. But we don't suddenly get to dementia. You know, I love it when I go to talk in senior communities and everybody laughs off the, I got lost, ha ha ha, we're all getting lost. Oh, I misplaced my glasses and keys, ha ha ha, we all do that. Right? Everybody wants to laugh away their problems or their cognitive issues. But when they become repetitive and noticeable, that's when you're saying, that's not what it should be. So the prodrome of dementia is a state called mild cognitive impairment, which is another way of saying not normal for age and not severe enough to be dementia. That is called mild cognitive impairment. Again, a categorical definition, not an etiological definition. So mild cognitive impairment due to ... Okay? And so we would see an observed memory self-report or informant-based report of a memory complaint objectively demonstrated without functional impairment. That's the criteria for mild cognitive impairment. And what we understand is, and this is the clinical criteria for mild cognitive impairment, you can objectively demonstrate. We use neuropsychological tests. We use other memory tests. We can actually demonstrate that there is impairment in their cognitive ability, but they're still independent. And there's a lot of people with current estimates are around 6 million people have mild cognitive impairment. Now, what I often do, and I see a lot of patients with mild cognitive impairment, one of the frequent things I order is neuropsychological tests. Some of you have had neuropsychological tests, I'm sure. You go to the neuropsychology, they exhaust you with 4 hours of questions, and you're frustrated and irritated by the time you leave. Any of you guys had neuropsych testing? Yeah, okay, so frustrating, right? Exhausting. So one of the things I ask my neuropsychologists, I say, is it amnestic or a non-amnestic? Is it heavily anchored in memory or is it not? Okay. Everything on the left-hand side of this slide is memory driven, and that is pre-Alzheimer's. Everything on the right-hand side of this line is not memory driven and is less likely to be Alzheimer's, less than 50% of the time. So I really like this categorization because we know that if you have a heavy loss of memory, you may be in the pre-Alzheimer phase of your cognitive problems. And so there's an algorithm for Parkinson's disease. Some of you have Parkinson's disease. Some of you are Dr. Evidente's patients. Some of you are other neurologist patients. And a lot of people with Parkinson's disease, after they struggled through all the complications of Parkinson's and the tremors and the falling and the constipation and the hallucinations and the psychosis, after you've struggled with all this, you need to understand that we're now recognizing, and Dr. Evidente will agree with me, that we're seeing more and more dementia related to Parkinson's disease. And it's called PD dementia, Parkinson's dementia. What I learned yesterday, just yesterday, is that it depends how long you have had Parkinson's disease. So if you've had Parkinson's disease, your probability of having dementia is between 3 and 12%. If you've had it for 10 years, it's 9 to 27%. If you had it for 15 years, it's 50%. And if you've had it for 25 years, it's 90%. So the longer you have Parkinson's, the more likely you are to develop dementia. Again, dementia means the dependent state, meaning you're no longer independent, not because of your mobility, not because of your tremor, but because of your cognitive abilities. That's the dementia phase. Now, I will say to you that in Alzheimer's disease, we can predict exactly who's going to progress to dementia. We're not guessing. Everything you read on Dr. Google is not always right. I will tell you, we are much more farther along developed in our research and our clinical practice than people recognize. I can tell you that if you are an amyloid positive on your PET scan, you're an APOE4 carrier, your medial temporal lobe, your hippocampus is below the 5th percentile, or you are 2 standard deviations below the mean on the neuropsych testing, you are very, very likely to progress to dementia. Now, we can predict not only are you likely to progress, when you're going to progress, how soon you are going to progress. We're not guessing anymore. So my point is that we're very precise on how we can predict who's going to progress from mild cognitive impairment to dementia. Dementia is the dependent state. Dementia is just worse. Mild cognitive impairment is the many cases the prodrome of dementia. Dementia just means your cognitive abilities have gotten to the point where you're no longer independent or you're relying on family members. What does that look like? That looks like you're getting lost. Family's scared for you to drive. You're no longer managing your finances. You haven't paid bills. This happened this week. Family stepped in because the patient stopped paying bills because she forgot to pay the bills. That happened this week as one of my patients. You can't shop anymore. You can't manage your personal affairs. That's when you can identify a cognitive decline that's affecting your daily life, that the family members or the loved ones have stepped in to take care of it. That's when you've crossed into dementia. Sometimes not very obvious to tell. In Parkinson's disease, it's really hard to tell because you have mobility issues. You have other motor problems. So people say it's because you have Parkinson. Maybe it's not related to cognitive issues. But eventually you can tell that it's not just your mobility. It's not just your Parkinson's. It can be because of your cognitive ability. So the dementia means you have a cognitive impairment with loss of independence. And so these are the criteria for dementia and Alzheimer's dementia. I already talked about the category. This is a long list. A lot of things cause dementia. Lewy body is second, vascular third, but Parkinson's is now in the top 5 causes of dementia. Okay? So it's a long list of things that cause dementia. Number 2, of course, is Lewy body dementia. So in our world of Dr. Evidente, in my world, people debate, is Lewy body dementia and Parkinson's dementia effectively the same disease? And we still are debating it. If you fill this room with neurologists, you get half of them saying they're the same disease and half of them saying they're not the same disease. I'm in the not the same disease category, by the way. Because Lewy body patients will get their Parkinson changes and their cognitive changes within 1 to 2 years of each other, okay? And they have a very different profile clinically. Number one is they fluctuate. What do I mean by fluctuations? My patients, I'll never forget my patients. My patients with Alzheimer's, very predictable. I can tell you what's going to happen next month, next year, very, very predictable. With Lewy body, and so it's like driving down the road. Lewy body's like going down the river. One day they're great, next day they're terrible, next day they're great, next day they're terrible, and you're like, what the heck is happening? What's going on? We don't understand. That's a fluctuation. Second thing is they act out dreams. Big time. Kicking, screaming, shouting, running, all this, hitting their partner. This is called dream enactment behavior, very typical for Lewy body dementia. Third is they hallucinate. I'm talking about seeing things. You know, they see animals and critters and spiders, and they see all those things. That is also typical for Lewy body dementia. And they're very sensitive to medications. Lewy body dementia is the most common condition that nobody's ever heard of, okay? And we're like, Lewy body, until Robin Williams had it, nobody had ever heard of Lewy body. And yet it's very, very common. Do you know who had a Lewy body? You're all of the age. Casey Kasem. Remember Casey Kasem? He died of Lewy body dementia. Ted Turner has Lewy body dementia. It's a pretty darn common condition that nobody's ever heard of. So just be aware of Lewy body dementia. Vascular dementia, you need to have either strokes in specific spots or a lot of white matter disease, and you have to have a chronological association with it. A lot of doctors tend to overcall vascular dementia. Most people with vascular dementia also have Alzheimer's, so we think of it as a mixed pathology, not just Alzheimer pathology or vascular pathology. Another condition, I work at the Barrow Neurological Institute. There are 29 neurosurgeons. All of my colleagues at Barrow want me to say that everybody has normal pressure hydrocephalus. This is water on the brain. And water on the brain has 3 specific features. They shuffle like this. Look like a Parkinson's gait, but people like Dr. Evidente and I can look at a Parkinson's gait and a water on the brain. And we're trained to do this. We can differentiate them, but they shuffle like people think it's Parkinson's because they shuffle, but it's actually a different quality of the walking. They tend to leak, they tend to pee on themselves, and they have cognitive issues. This is the treatment involves a shunt, meaning you put a tube in their brain, drain the fluid. I've had patients have remarkable, amazing recovery from the normal pressure hydrocephalus. I never forget a woman who came to see me. She had water on the brain, normal pressure hydrocephalus. We put a shunt in, and she was in a wheelchair when she saw me for the first time. 6 months later, she walked in, hugged me, and said thank you, and she was completely back to normal. So it can be very, very, very dramatic. So that's the first thing I want to talk about is Alzheimer's, dementia, Parkinson's dementia, Lewy body dementia. Now I want to spend the rest of the time talking about the major changes in Alzheimer's disease. So this is the same thing is happening in Parkinson's disease. When we're trained, as Dr. Evan and I are trained as neurologists, and he went into subspecialty movement disorder, I went into subspecialty dementia. We were trained to diagnose our patients on clinical symptoms. Like in an Alzheimer's world, if they're repeating themselves, they're getting lost, they're misplacing glasses and keys, that's a clinical description of an Alzheimer profile, okay? We are now moving away from that. We're saying we need to define the disease by the disease in the brain, not by the clinical symptoms. So we are now going for a biological definition. I'll give you an analogy. I remember very distinctly, if you had diabetes, and when we were in medical school, it was polyuria, polydipsia, polyphagia. You ate too much, peed too much, and drank too much. That was the clinical definition of diabetes. Nowadays, we don't use a clinical definition. We look at your blood tests. You have an A1C, hemoglobin A1C, fasting blood sugar, fasting insulin, glucose tolerance tests. In other words, we define diabetes as a biological disease, not a clinical disease. We're doing the exact same thing in Alzheimer's. So the reason I say this to you is that we used to just go to the doctor, and I know most neurologists in the city are still doing this. This is now so 2020. We're now into 2024. You got to keep up, right? So the reason I say this is that we used to just exclude other things: stroke, tumor, water on the brain, check your thyroid, check your B12. and kind of by accident default into a diagnosis of Alzheimer's. How accurate is that? In primary care, it's only accurate 60% of the time, and in specialty care, only accurate 70% of the time. Turns out it's not very accurate. So that's why we're moving away from just defining it clinically. And so I led a study a few years ago when I was in Sun City, Arizona. The world experts called this group of people Alzheimer's, meaning we said clinically this patient's had Alzheimer's, we got their scans of the brain, we followed them to autopsy, and we world experts were wrong 1 out of 4 times. Even we, the world experts, were wrong 1 out of 4 times. So 1 out of 4 times they didn't have Alzheimer's in their brain. That's what I'm trying to tell you is if the world experts can't tell, good luck with everybody else. So I'm trying to say to you that that's why we're moving toward a biological definition. So the diagnosis of exclusion, meaning excluding other pathology, is being replaced by the diagnosis of inclusion, which is biomarkers. So we actually have a lot of biomarkers now, spinal fluid, blood tests, PET scans. We're using them to diagnose, we're using them to predict progression, we're using them to assess for treatment response. And that's because there's been a major evolution in the way we approach it. We learned, you learned, you can only diagnose Alzheimer's with an autopsy. That's what you read on the internet. My medical students that come into my clinic this week are being still taught that in 2024 that you can only diagnose Alzheimer's with an autopsy. That comes from the 1984 NINDS ADRDA criteria. But I will tell you right now, in 2018, we redefined it as a biological disease, which was redefined in 2024 as a clinical biological disease called the ATN criteria. So let me get to that. If we're going to use those new treatments, the monoclonal antibodies, the Kisunlas and the Kembis of the world, you need to define your patients as having the disease. So we used to look at MRI to check you for stroke and tumor and water on the brain. Well, we don't do that we don't just use MRI that way anymore. We want to look at parts of the brain called the medial temporal lobe. That's this orange arrow. That's shrunk. That's a marker of neurodegeneration. That's predictive of progression. We can now quantify how much white matter disease. A little bit is age-related, a lot might be vascular, and we're now using MRI in a much more sophisticated and granular way to look not just for stroke, tumor, and water on the brain, but for other pathologies as well. A big discussion, and I'm one colleague here from GE Healthcare and Avid Lilly are here today, and we're spend a lot of our time now. Amyloid PET was approved in 2012, 13, and 14. Until 6 months ago, amyloid PET was not paid for by Medicare. 6 months ago, Medicare finally stopped pushing back, and now I can get amyloid PET paid for. And it's a big, big advance. So what is this? This is a marker, direct marker of amyloid pathology, Alzheimer pathology in your brain. What I like to look at is this upper right-hand panel. You see the gray matter and the white matter very clearly differentiated. That is a negative scan. That means there's no amyloid in their brain. But when it's blurry, as it is on the upper right-hand panel, that's a positive scan. That means there's amyloid in the brain. So we can now use amyloid PET scans to determine, to confirm you have Alzheimer's disease. Not a proxy measure, a direct measure of the disease in your brain. And yes, finally, Medicare is paying for it. This technology has been around more than 10 years. It just was never paid for until 6 months ago. So I'm not trying to go hard science on you. I just want to take the science and translate it into plain English. But the reason I'm saying this to you is that the clinical symptoms of mild cognitive impairment and dementia are the end of the disease. The end of the disease. By the time you walk in the door, your brain is full of disease. Let's say you have Alzheimer's. Your brain already has amyloid and tau and plaques and tangles. So the clinical stage, the mild cognitive dementia, is what we call the end-terminal stage of the disease. Using the diabetes analogy, it's like diagnosing diabetics when they're already going into renal failure, into kidney failure. That's how far along patients are. That's how far along we're diagnosing patients. So we know we can use the biomarkers now to diagnose patients before onset of symptoms. And we now know that the biomarkers precede, the amyloid and tau precede the onset of symptoms. So so one of the things that is approved and available is spinal fluid analysis. Now, I know what you're all going to say to me is, ooh, that seems awfully invasive. It seems a little bit heavy-handed and excessive. Why would we do a spinal tap? Well, let me tell you that if you had meningitis, encephalitis, or other diseases of fever, altered mental status, other things, and you go to the emergency room, they're going to do a spinal tap on you, or they should be doing a spinal tap on you. We do spinal taps for about 30 different reasons. There's no reason why you can't do it for Alzheimer's. I know patients prefer the PET scan, but spinal tap is an option. And I know it sounds scary, but the truth is, I do them myself. It takes me all of 5 minutes. It takes you longer to park your car, come up the elevator, check in, and get into the room than it does for me to do the spinal tap. I'm in and out in 3 minutes, 3 to 5 minutes. It's very quick nowadays. But they're direct measures of amyloid and tau. We can now directly measure the disease in your brain with spinal fluid. It's remarkably accurate. So when they looked at a study of amyloid and tau, 200 studies in 20,000 patients, we showed that the specificity and sensitivity, these are markers that Dr. Evidente used, when it's highly sensitive and highly specific, that means it's a very, very accurate test. Over 95% sensitivity and over 95% specificity. So spinal fluid is remarkably accurate. The other thing is that amyloid, the spinal fluid correlates well with PET scan. So people say, which one should I do? I say either or. You can either do amyloid PET or spinal tap. Nowadays, and when I'm talking nowadays, that means like every few months things change. I order the spinal tap if your insurance company does not allow the PET scan to be ordered, which, by the way, the good news is I said amyloid PET is covered. The bad news is that insurance companies sometimes still push back on me, and then I'll be talking about a spinal tap. But it turns out that you can use either or. Now, people who are still skeptical understand this. On the left-hand side, it's saying you that if your amyloid is down and your tau is up and your spinal fluid, 98, 99% chance you have Alzheimer's. So it's very, very good diagnostically. If your amyloid is down and your tau is up, on the right-hand side, it shows that you're very, very likely to progress to dementia in 5 years, 90% chance. So it's both diagnostic and predictive of progression. Now, the good news for you is we now have the blood tests for Alzheimer's disease. If Dr. Evidente had invited me a year or two ago, these were just being developed. They are now approved. The first blood test is checking for amyloid. Blood test, did you hear what I said? Blood test for Alzheimer's. Okay, this is a big deal. So we would measure a protein called amyloid. In blood, it goes down. And it shows that it correlates very, very, very well with spinal fluid. It predicts progression, and it correlates with other things. And there are now 3 blood tests approved. LabCorp has one, Quest has one, and a company called C2N Diagnostics has one, and has decent sensitivity and specificity. Another one we look at, and my world is very focused on tau. So amyloid accumulates in your brain. So in blood and spinal fluid, amyloid levels start to fall because the conventional wisdom it's being sucked up into the plaques, into the brain. But what happens is your brain gets injured from the amyloid, and then once the brain is injured, you start releasing proteins called tau. So amyloid goes down in the blood and spinal fluid, tau goes up because the brain is being injured. And those are specific proteins for injury related to Alzheimer's disease. So what we expect to see is that if your amyloid is down and your tau levels, there are 2 kinds of protein in tau that we can measure now in blood. One is called p-tau181 and p-tau217. And what we show here is that if your p-tau181 is up, you are going to get worse over time. Very, very predictive of progression to dementia. And this is, again, available in the LabCorp catalog. But the money test, I just got back, and so it's available. Sometimes insurance company pays for it, sometimes it doesn't. Every time LabCorp has a new test, the vice president calls me and says, hey, start ordering all these tests. And I said, sure, what are the codes? So in our world, Dr. Evidente, in my world, it's all about the code. What is the CPT code and ICD-10 code? You got to put the codes in, otherwise Medicare doesn't pay for it. So it's all about the codes, okay? It's attention and concentration deficit, other amnesia, and mild cognitive impairment are the codes, by the way. So I just want to know. So the one test that we are all excited about, I just got back from the Alzheimer's Association International Conference in Philadelphia about 3 weeks ago. The AAIC was our major Alzheimer trade meeting. And one of the major discussions is about this blood test called p-tau217. This is considered in my field to be the money test. Like if you need one, if I can get one blood test, which blood test is it? And it's this one. I want to show you the right-hand panel. It's suggesting that if your p-tau217 levels are above a certain cut value, a certain range, you have 96% probability of Alzheimer's disease in your brain. 96%. This is a study out of Sweden called the Biomarker study. This is tremendously accurate. So p-tau217 is a blood test that we now have started drawing. It's only been in my clinic for 4 months, less than 6 months I've had it on my catalog. So people ask me, should I do amyloid? Should I do the spinal tap? Should I do the PET scan? Should I do the blood test? And the way I do this is this. We're going to talk now about the new treatments for Alzheimer's. That's the next part of this talk. I will use the blood test for what's called the negative predictive value. In other words, I use them to exclude disease. If your values are normal, I will not go on for more tests. But if your values are abnormal, I will go on and order more tests. Why is it that way? Because I'm not ready to just give you a monoclonal antibody, a very involved infusion treatment for Alzheimer's, just based on a blood test. I really, really still need to see a PET scan or a spinal tap. And so the answer is yes, I'm using the blood test as what are called gating tools, meaning screening patients for whether they have the disease. So what's going on in the Parkinson's world? This is much more Dr. Evidente's than mine. One thing you understand in Parkinson's, we've had now for several years, the DAT scan. DAT scan looks for dopamine transport in the brain using something called SPECT. Interesting thing about DAT scan, it's really expensive, but it's covered by Medicare. If I order a PET scan, which is 1/3 the cost, not covered by Medicare. So I don't understand. PET scan is 1/3 the cost, they won't cover it, but DAT scan, 3 times the cost, they cover it. The other thing people are working on is biopsy of your skin, biopsy of your salivary glands, spinal fluid analysis for Parkinson's. In fact, there's now a study suggesting that you can diagnose Parkinson's disease with a spinal tap. And I will tell you that I'm leading a study now to see if we can compare that spinal fluid analysis to blood, because we think we may be able to develop a blood test for alpha-synuclein. A lot of companies are working on that. So what I'm saying is, just like Alzheimer's, Parkinson's making similar progress in similar areas. So let's spend the rest of the time talking about treatment. My day job is changing based on this slide. People say to me the drugs like Aricept and Exelon and Razidine and Namenda, they don't work. That's what they say. Everybody says that. These drugs don't work. And you read that on the internet and they don't work, right? These are symptomatic drugs. These are purple, that's the purple hashed line. What you don't understand is that these are symptomatic drugs. They were never going to change your disease. Understand this. If you take Tylenol for your back pain and your knee pain, you take away your back pain and knee pain, but the Tylenol did not take away the arthritis that causes your back pain and knee pain. It just improved the symptoms. Do you follow me? Aricept, Exelon, Razidine, Namenda, same. These improve the symptoms, but don't take away the disease. So you're getting worse whether you're on the drugs or not. And so people say to me these drugs don't work. Not true. That's the purple hash line. We now have the green dotted line, which is the new disease-modifying therapies, and we're now combining them. That's the solid blue line. When I say to you, for the people who are skeptical about the amyloid hypothesis, I say to you, you're not living my day job. You're not living in my reality. The fact is Dr. Evidente and I know each other 25 years. He's a Parkinson guy, I'm an Alzheimer guy. We see each other, we compare notes. All of us, Dr. Evidente and I have been at this a long, long time. And I will tell you that we have had a lot of advances recently, but a lot of setbacks. This slide here is all the drugs that failed in the last 20 years. This slide is 40 billion with a B, $40 billion of investment. So the reason I say this is that every time we fail, we learn. And we learn a lot, and we get better at this. We understand amyloid biology. We understand that you make amyloid from a larger protein called amyloid precursor protein, and then you create something called a monomer, which is a nascent protein. In other words, the brain doesn't react. The brain thinks that's a fine thing. It's only when you get to the oligomer, that we say, ooh, that's not a good idea. And that's when your brain starts to react and get the inflammation, the neurochemical breakdown, the excitotoxicity, the tau accumulation, et cetera. And so the new treatments are targeting the advanced species of amyloid. The other thing we understand is that amyloid is important, but it's not the only thing that's important. So the reason I say this too is that here's amyloid. So the idea is, why don't you prevent its production? Why don't you just give them medicine to stop the production of amyloid? Well, we tried that. It didn't work. In fact, it made people worse. So that's why you got the monoclonal antibodies. And then you have, of course, other things. We can target inflammation and tau and tangles in ApoE. So how did we get to the Leqembis and Kisunlas of the world? The chart starts out 25 years ago when Dale Schenk said, let's treat amyloid like an infection. And he started giving a vaccine to a mouse. The vaccine was called AN-1792. And we showed 25 years ago, we thought we had cured Alzheimer's. We thought we had cured Alzheimer's. I'll never forget this study. This is the AN-1792 study. And what it showed is they got phase 1 done, they got to phase 2. I remember being in Sun City, Arizona. I was the director in Sun City, Arizona. And I was upset because I didn't get this study. I was really mad. I'm like, damn it, I didn't get this study. Typical study like this, 360 patient study, takes about a year to enroll. They enrolled it in 6 weeks. People were literally lining up to get into this study. That's October of 21. I'll never forget, 2001, October of 2001. January of 2002, we started hearing noise. And by March of 2002, they stopped the study because there were 18 cases of encephalitis and 5 deaths. And we go, ooh, that's bad. But when they looked at their autopsy, sure as heck, it cleared the amyloid out of the brain. It worked. We had the wrong approach, but what we showed is that fundamentally we could alter the disease first time ever, 2002. This is published in Nature. This is the Nickel paper in 2004. So then they said, instead of going for the monoclonal, for a vaccine, because the problem with the vaccine is when you inject a vaccine into a person, I don't care what kind of vaccine you're talking about, there is no off switch. There's only an on switch. You're turning on your immune system. You don't have an off switch. So that's why monoclonal antibodies came around. So in 05, 06, they started creating monoclonal antibodies to Alzheimer's. The first one was called bapineuzumab and solanezumab. And what it showed is that they could, for the first time ever, with the monoclonal antibodies, we could remove amyloid. We did it pretty well, but it didn't show any clinical efficacy because we were afraid of what the changes were. At the same time, another drug called solanezumab was coming along, showing a little bit of a clinical signal, little bit of a clinical signal. And they decided after the fact that they only had a set 11% change. This is the Lilly drug, solanezumab. I was in the room, for my Lilly colleagues were sitting in the back of the room. I was in the room when Lilly sat and made the decision to walk away from solanezumab. They had pre-specified a 15% change between treatment and placebo. They got an 11% change, and $2 billion later, they walked away from this drug. I want to tell you how these drugs, these studies do not come easily or lightly. They're very, very difficult decisions to make along the way. So then we also had a third drug called gantenerumab. Gantenerumab showed resoundingly we could remove amyloid, but it didn't have a clinical efficacy signal. So they went into the phase 3 trial called the graduate study, cranking up the dose 5x. And again, they were looking for a 25% efficacy signal. They got an 8% efficacy signal. Again, $1 billion later, walked away from this drug. So let's talk about the new drugs that have been approved. First one you need to understand is that the drugs donanemab, aducanumab, lecanemab target advanced species of amyloid. So like I said, the early species of amyloid doesn't, but once we get to the oligomers, protofibrils, fibrils, and plaque, you need to start, these are what the new drugs target, is the advanced species of amyloid. The first drug that was approved was aducanumab, also branded under Aduhelm. And people who are skeptical that this drug works, people say to me this was a backroom deal that the FDA made with Biogen. And I say to you, again, live in my world, sit in my world, and I'll tell you that's not how these things go. Okay? What happened is that they did a phase 1 study. This is the Sabbagh paper. This showed for the first time ever that in a dose-dependent manner, the more higher the dose, the more amyloid was removed, and the higher the dose, the more slowing in the rate of decline. Okay, amazing. And it shows this is the placebo people. That means they got no, and this is the red is amyloid. Cleared it out completely, cleared out the amyloid out of the brain. We were excited about it. We were excited about this drug. I think Biogen kind of got ahead of their skis. They went straight from a phase 1 to a phase 3 trial, and showed mixed results, failing. It got approved anyways on a biomarker endpoint. So what happened is this. FDA said we're going to use a cancer approval mechanism. In cancer, all you have to do is show that you shrunk a marker on your cancer marker. So if you have a lung cancer and your tumor goes from 2 centimeters to 1 centimeter, that's a shrinking of a tumor marker. That's enough to get a cancer drug approved. That's exactly what the FDA said. Let's use the cancer approval mechanism for Alzheimer's disease. They've done it 250 times, and people scream bloody murder like they're cheating and other things. No, none of the cases. So aducanumab was approved in June of 21, was taken off the market in January of 24 because Medicare said we're not paying for this. In the same time, lecanemab or Leqembi was developing, and this is the study. I was actually on the New England Journal paper, very proud of this work. And what it showed in the phase 2 trials that the 10 milligram per kilogram group could effectively slow the rate of decline. And they just finished the Clarity study. This was published on November 27th, 2022. What it showed is that on a large instrument called the CDR, this is a huge study. This is 1,800 people. They were either randomized to lecanemab or placebo. The people need to understand that everybody, whether you're on lecanemab or placebo, actually are already on Aricept and Namenda. So this is standard of care plus placebo versus standard of care plus lecanemab. And it showed that it slowed the rate of decline 27% compared to placebo. Okay? This was a big deal. This is the second time ever we saw in a dose-dependent manner, the higher the dose, the more amyloid was removed, the more slowing the rate of decline. And what it showed is they removed amyloid 90%. 90%. So this drug removed amyloid resoundingly well. And so that was a big breakthrough. And it showed on an instrument called Activities of Daily Living, the IADLs, 40% slowing on the rate of loss on the instrumental activities of daily living. So at the end of the study, the people who got Leqembi were 40% less impaired compared to placebo. What you also need to understand is that the new drug Kisunla was approved 7 weeks ago. Kisunla is donanemab, also removes amyloid, also intravenous, also targets amyloid. But Leqembi targets the protofibril. Kisunla targets the pyroglutamated epitope of the plaque. So same amyloid, different species of amyloid. And what they showed in their early phase 2 trial is that on their composite measure called the iADRS, they slowed the rate of decline 32%. And when they went to the Trailblazer ALZ study, this is the study just published in the New England Journal, no, this is published in JAMA, July 17th, 2023, because again, I was in the room at AAIC when this was announced, showed that they could slow the rate of decline about 29% compared to placebo. And they used it, whether it was on the CDR or on their global measure called the iADRS, when you had a lot of tau or a little tau, it had remarkable effects across the board. And I want to show this to you very carefully. So this patient B, the red on the left-hand side, that's amyloid, brain full of it. At the right-hand side, no amyloid. This drug, donanemab, Kisunla, removes amyloid like gangbusters. We're talking about the fact that within a year, you have no more amyloid left. And so we are very excited to have 2 options now, Kisunla and Leqembi, to treat Alzheimer's disease. But there are a lot of cautions you need to, before you start running out and saying, I really like this idea. There are a lot of cautions. This is not a drug for everyone. And what I actually showed is that, again, they're slowing in the rate of decline. Now, what are you buying? What are you buying when you get these treatments? People always look at the y-axis. They look at the up and down difference between treatment and placebo. I want to look at the x-axis across the board. When you see that red arrow, what you're showing is that the placebo group hit a point of crossing a threshold 6 months before the treated group. And so it's important that you understand that what you're buying is delay of progression. You're not getting better, you're getting less worse. Got it? You're not getting better, you're getting less worse. That's what you're buying. But if you have mild cognitive impairment and you don't want to get to dementia, our goal is to prevent, delay, or postpone you from getting to dementia. What you're buying is that. You're buying the ability to postpone the dementia. There are complications. One is called ARIA. Let me see if I can talk about ARIA. But we'll talk about ARIA in a second. Now, I want to talk about ARIA in a second. But people say to me, amyloid is still not, I hear the argument, amyloid is still not important. I hear this. That's what people say to me. The amyloid hypothesis is still not relevant. Why do I want to clear amyloid? And the answer is that when you remove amyloid, everything gets better. Your tau levels start to fall, both in spinal fluid and plasma. Your inflammatory markers and your neuronal injury markers start to fall as a result of, so removing amyloid, your brain's much happier when there's no amyloid, your tau levels and other markers start to fall. So the one thing you have to understand that we learned a lot about these drugs. There is some cautions, there are restrictions. They're not for everybody. It can only be in mild cognitive impairment or very mild dementia. The APOE genotype is relevant. If you have a lot of microhemorrhages in your brain, that's relevant. If you have a pacemaker, you can't get this drug. You need frequent MRIs. You need to understand that we have to confirm you have amyloid, and a lot of things need to come along with it. And one of the things you have to understand is there's a condition called ARIA, or brain swelling. This is the boogeyman of the drugs. You read the internet, this is what you read about. Brain swelling, brain bleeding, etc. And it scares the people, it scares everybody. And I will tell you, these risks are real. What I also want you to know that in Leqembi, depending on your genetics, the risk is somewhere between 5 and 33%. And for Kisunla, it's 12 to 44%, depending on your genetics. Second thing we understand is that 80% of the time it's asymptomatic. In other words, the only reason we see it is because it shows up on a scan, not because of symptoms. And only 10% of the time is it symptomatic, and most of the time it's manageable. But again, it's a lot of these decisions are made based on selecting the patients very, very carefully. I already have 40 prescriptions for Leqembi and 1 for Kisunla, and we manage these things very, very carefully. We actually spend a lot of time and a lot of effort to make sure that we're doing these things quickly. So ARIA rates depend on your genetics, how many microhemorrhages you have, what kind of drug you have, et cetera. So Kisunla, if you're not carrying the genotype, is 12%. If you have a single copy of the genotype, it's 24%. If you have 2 copies of the genotype, it's 44%. For Leqembi, it's 5% if you don't carry the genetic marker, 33%, no, 15% if you carry 1 copy of the genetic marker, and 33% if you carry 2 copies of the genetic marker. So a lot of it's dependent on that. I'm going to close up here in a few minutes. There are a lot of drugs. I want you to see this slide here for a second. There are 127 drugs in development for Alzheimer's disease. 127. Every year, my colleague, Dr. Cummings, publishes this paper because this is kind of a snapshot of everything in the drug pipeline. And it's not all amyloid. Tau, energetics, inflammation, epigenetics. There's so many things that are going into the treatments for Alzheimer's disease. And we think the future of Alzheimer's is chemotherapy, not a 1-drug cocktail, but a 5 or 6 drug cocktail to truly slow and arrest the progression. And this is just kind of a breakdown of all the different categories. And what you see is that amyloid is a relatively small percent of the drug targeting amyloid, a relatively small percent of the drugs being targeted. People say to me, why are we spending all our time talking about amyloid? Why don't we treat tau? Tau is a marker of injury. And the answer is, what is tau? Well, tau, if you want to know, is you see these large proteins called microtubules? See that green over there? Those are these are what are called trafficking proteins. They're like railroad tracks in your cells. You use the railroad tracks to move things up and down your cells. Tau are the cross hatches. Tau are the little proteins that keep those microtubules lined up. In Alzheimer's, what happens is they start getting chemically altered. And once they become chemically altered in a process called hyperphosphorylation, they stop binding to microtubules, and literally the microtubules start flying apart. And then it literally damages the cells, and they stop trafficking things up and down, and the cells fall apart. And so then there's a concept here called preanosis, where these little forms of tau that are floating around start to be taken up by the adjacent cells in a process called preanosis. So the idea is we should just target tau. Turns out, of course, it's really hard to get things into the brain, and it's really, really hard to get things into the cells themselves. So we have not had a huge amount of success. It does make sense because it correlates very well. Tau spread correlates very, very well with clinical progression. And so there have been a lot of failures with monoclonal antibodies against tau. Until this year, in 2024, there's a drug called BIIB080, BIIB080, BIIB080. And I tell you about it, it's called an antisense oligonucleotide. You inject it, scary, you inject it in the spinal fluid. You inject this treatment in the spinal fluid, but it removes that tau like gangbusters. And so we are very excited. For the first time ever, we can now see tau levels start to fall. And so we could see the next treatment coming forward. What about other things? Turns out that people now realize that there are other drugs already approved for Alzheimer's disease. There's a drug called Belsomra, Sorexevant, which is a treatment for the sleep-related disturbance in Alzheimer's disease. And then just last year, a drug called Rexulti or brexpiprazole approved for the treatment of agitation in Alzheimer's disease. So we're seeing more and more drugs being developed for Alzheimer's, and lots of new drugs and new targets. And with that, I will tell you that we are in the transformative moment. We're transforming Alzheimer's disease from a terminal disease to a chronic disease. This is the diabetes and HIV of our time. We are going to use a multi-drug cocktail to get there. We're going to use precision medicine to diagnose people with accuracy, going from 60, 70% to over 95% accuracy, and it will be biomarker driven, and lots of new drugs are being approved. And with that, I thank you.